Dok.
Pagi Dokter Krisna.
Dok, background soundnya nggak terlalu kenceng nih, Dok. Di,
Oh,
Selamat pagi, Dok. Kenceng kan?
pagi Dokter Krisna.
Dok, background soundnya nggak terlalu kenceng nih, Dok. Di,
Oh,
Selamat pagi, Dok. Kenceng kan? Kok eko ya, Dok?
pagi Dokter Krisna.
Dok, background soundnya nggak terlalu kenceng nih, Dok. Di,
Oh,
Selamat pagi, Dok. Kenceng kan? Kok eko ya, Dok?
pagi Dokter Krisna.
Dok, background soundnya nggak terlalu kenceng nih, Dok. Di,
Oh,
Selamat pagi, Dok. Kenceng kan? Kok eko ya, Dok?
ada teman-teman UI udah gabung belum? Dokter Krisna?
Oh
Belum
iya,
terlihat.
belum, Dok. Sebentar, Dok.
Heeh. Nanti kayaknya hari ini banyak nih UI, UNER, UNS. Teman-teman dari neuro juga. Bu Eva, good morning. Selamat pagi Bu Eva.
Selamat pagi, Bu.
Apa
I'll be
kabar?
on baik-baik. Apa kabar?
Alhamdulillah baik. Bu Eva sehat ya.
Ya, sehat selalu, Bu.
Selamat pagi, Bu Eva.
Halo. There you are. Yes, at the
Iya,
top. I see. Yes. Apa
iya.
kabar?
My name is Krishna, Dr. Eva. Your
Oh,
Indonesia is very good.
thank you so much. Masih belajar ya. How are you today?
I'm great. How about you?
Oh, good. Here I am. Turn on the
You are
video.
in the space.
Yes.
Yes.
All inclusive.
Yeah, we will wait a second
Yeah.
until 9 a.m. at Western Jakarta time.
Yeah, I'll mute for the moment, so I'm not interrupting. Okay,
Okay.
see you soon.
But Bu Eva no stay at Bali kan Bu Eva ya?
Sorry?
Bu Eva sekarang kan di Bali kan?
Yeah, di Bali.
Mm-mm. Jadi no different time issue ya?
Yeah, almost 10 o'clock. No
1
problem.
hour, 1 jam mungkin.
Dia
Yeah,
beda 1 jam.
Mm-mm.
it's no problem. All good here. I had my coffee ready to go.
Okay. So you will deliver the lecture in English or in bahasa Indonesia, Dr. Eva?
English, because
In
my
English.
work knowledge of Bahasa Indonesia is not good enough.
For the conversation. Okay, sure.
Yeah.
Yeah. Or you can use mix if you want to.
I'll do my best. I think for the questions, we can receive them in both language if it's easier
Ah,
for people, and then I can check with Busri and yourself to make
I
sure
can
I,
translate it for you.
yeah, or I
Yeah.
can make sure I understood correctly, and you can correct me if I went in
Okay,
the wrong direction. Okay,
perfect.
I'll mute myself and let you all get started there.
Shall we start, Bu Eva, Dr. Krisna?
Yes, let's begin.
Oke. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi pada Bu Eva yang sudah hadir as a lecturer pagi ini. Ada Dr. Krisna as a moderator dan adik-adik semua, para partisipan dari beberapa universitas dan beberapa rumah sakit yang sudah hadir. Terima kasih sudah join dengan program untuk Strengthening Qualitative Research Publication in Long-Term Care yang merupakan mata kuliah elektif di bidang penyakit dalam untuk PPDS penyakit dalam terutama SP1. Ini adalah serangkaian program dari 3-in-1 yang akan mendatangkan, yang telah dan akan mendatangkan guest lectures. Yang seri pagi ini akan kita ikuti bersama dua topik kuliah dari Bu Eva. Yang pertama adalah Introduction to Dementia tentang konsep, types, and clinical recognitions. Dan yang kedua adalah Non-Pharmacological Intervention in Dementia Care. Bersama kami semua, ada Bu Eva dan ada Dr. Krisna nanti sebagai moderator. Untuk kelancaran acara pagi ini, mari kita buka dengan berdoa supaya apa yang kita harapkan dari pertemuan ini bermanfaat dan untuk besar-besarnya manfaat untuk pasien dan sesama untuk membantu dalam hal kita pelayanan dan pengabdian pada masyarakat. Berdoa dimulai. Berdoa bisa diakhiri. Kami mohon maaf, memintakan izin karena Bapak KPS kami berhalangan karena ada tindakan di ruang operasi, sehingga acara ini kami buka sebagai penanggung jawab kegiatan. Untuk berikutnya kami persilakan Dr. Krisna Septiandi Runtuk, SPKJ, untuk mengawal jalannya acara. Kepada yang paling kita hormati pagi ini Bu Eva dan Dr. Krisna, kami persilakan waktu sampai jam 11.30 atau sampai jam 12 bersama diskusi. Kami persilakan.
Ya.
Time is yours, Dr. Krisna and Bu Eva. Thank you.
Terima kasih Dokter Sri Sunarti. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya. Salam kebajikan bagi kita semua. Uh, Terima kasih untuk kedatangannya, Prof. Dokter sekalian, dan juga mungkin bagi peneliti-peneliti yang tertarik ya dalam bidang demensia. Good morning, distinguished guest speaker, Dr. Eva, and respected faculty members, colleges, residents, students, researchers, and healthcare professionals. Welcome to guest lecture series 3-in-1 program titled Strengthening Qualitative Research Publication in Long-Term Care. So this today's session is the part of the elective course that was mentioned by Dr. Sri Sunarti about elective course for internal medicine residents. And we are honored to have participants joining us from various institutions too, from the resident from other university. I can see maybe from Airlangga and maybe from Universitas Indonesia maybe. Thank you for your coming here. So we have our guest speaker today is Dr. Eva van der Ploeg. We will deliver 2 lectures. So the first lecture is Introduction to Dementia, Concept, Types, and Clinical Recognition. And second is Non-Pharmacological Intervention in Dementia Care. So I will read about curriculum vitae of Dr. Eva. Dr. Eva van der Ploeg is a research psychologist doing studies in real life setting and working in practice. Dr. Eva has a Master of Science in Psychology and doctoral in Public Health. So her practice work is grounded in teaching of person-centered care and mindfulness. Uh, she do a Montessori for dementia. So I have watched her video since 2015. So it's Dr. You are very familiar for me, like I think I have seen Dr. Eva before. So she's doing many things, especially in dementia and older people care, like Dr. Eva. She's specialist working with people with dementia and those who care for them, for the caregiver too. And she also provide mindfulness coaching and meditation for general population. And now interest is emerging in people living with central nervous system disorder. So right now is working in University of Applied Science Utrecht, right, Utrecht. Okay, we will start our lecture today. Dr. Eva, time and screen is yours.
Thank you so much, Dr. Krishna and Dr. Sri as well. Good morning, selamat pagi, assalamualaikum, and Om Swastiastu from Bali, Denpasar. I will be delivering my lecture in English. I do understand a fair bit of Bahasa Indonesia, but to deliver my message effectively, I think it's best to revert to my first language. I would like to share my screen. Let me see if that would already work. I need to get some permission before I can share my slides. So if somebody I'll just wait a moment before. I have sent a request for sharing. Yes, perfect. Here we go. We'll start here. There we go. There will be a discussion question section at the end of this first lecture. So unless something is really unclear, I would like to encourage you to hold your questions until the end. That just adds that little bit of flow. This course is about interview studies and how to do them. But I think for today, we dive much more into what could you study in our field. And as the introduction said, I'm a specialist in dementia. So we'll be talking a lot about what is dementia and how can you as a clinician recognize it, diagnose it, what would be the next steps. And then the second part or the second lecture today, we're going to be talking about non-pharmacological, so non-medicinal interventions that are in place. And I will briefly touch on what's available medically speaking. But if you know a little bit about dementia, you know this is, there's a lot happening, but not so much working. We'll get to that later. Let me start with an introduction to dementia. So this is what I'll do in the first roughly 1 hour. I'm going to explain what dementia is, and I'll start with the questions that I'm asked most frequently. That's just a way of easing all of us into the subject, but also as well, if you have any questions about dementia before we start, it's quite likely that they're in these questions already. So I hope to take away anything that's strongly on your mind, and then from there, we can focus on the rest of my story. I'll be explaining the difference between normal aging, mild cognitive impairment, and dementia. The types and/or causes of dementia. I'll explain a little bit more why I say types and/or cause. How does it relate to other conditions, including psychiatric conditions? How do you recognize this? And it's not as straightforward as we would hope for, but there is definitely some tools to help you recognize it in practice. Some tips around the diagnosis time, and then I want to talk a little bit about stigma. The beginning of this part of the lecture is mainly quite factual. It's a description of what is dementia, what is normal aging. But I do want to also emphasize that some of what I'll be presenting is my take or interpretation of dementia. There's so much unknown, so maybe another professional would use different words or has a different perspective. And I'll try to always acknowledge when I'm talking from my own experience of 20 years versus, this is more factual. So let's dive into a bit of facts first. So the first question that I'm asked definitely the most, almost every time I speak, is, are dementia and Alzheimer's syndrome the same? And the very short answer is no. Basically, you can see dementia as the overarching umbrella. And if I would need to describe it very shortly, it's just brain damage. Any damage to the brain in any area that prevents the person from functioning. And then Alzheimer is actually a cause of brain damage. So when you develop Alzheimer's progressively over time, the brain becomes more and more damaged. It is also called a type of dementia. And as I said before, I'll explain a little bit more why I call it a cause. The second question, how many causes of dementia are there? As you can see, it's a wide range from 50 to about 100 causes of dementia. And this includes a lot of causes from which the impact might be reversible. Think of road accidents, infections, and delirium. And again, I will talk about this a little bit more. This is just the briefest of introductions. And other causes, which will be more the focus of today, are Alzheimer's, vascular, Lewy body, prefrontal, and mixed type dementia. The next question, will everyone develop dementia at a certain age? Again, the short answer is a definite no. However, the older we grow, the more at risk we are at developing dementia. And at the age of 85 and over, roughly 50% of people will have some form of dementia MCI. The onset is usually after 65 years of age, but it can definitely be earlier and much earlier as well. I think the youngest person I've ever encountered was 38 years of age. And around 45% of all dementias, due to the causes I just highlighted, can actually be prevented through the targeting of lifetime risk factors. Again, I will dive into that just a little bit more, but it means almost half could potentially be prevented. I do need to make the note that this is ongoing work. It's great work by the Lancet Commission on Dementia. If you're very interested in the area, I would definitely recommend after this lecture to immediately Google their work. They have these huge packages of paper that will give you so much more background than I can share with you today. So what are the risk factors of dementia? Again, I'm just quoting my source here at the top, but the latest update was in 2024. They had added 2 additional risk factors compared to the previous report. And it's a huge range of factors. So it includes education, which can already be targeted in early life. So what we get in terms of education from primary school is important for our risk of dementia. Some people get very disheartened by this news because they go, well, I can't go back and change that part. However, one of the recommendations is that a lifelong learning is very helpful as well. So if you had only basic primary care at any stage in your life, you can still choose to go back to university, maybe at an older age, or do courses, etc. There's a lot of physical health factors in there that are mostly all related to heart health. So think of diabetes, obesity, but also physical activity. So in a way, all these 3 would be connected. However, they're all mentioned as separate risk factors. And obviously, the more risk factors you have, the higher your chance. But then there's also psychosocial factors such as depression, and again, separate from depression, also just plain social isolation. And there's a really sad interaction between dementia and social isolation, as you will see later. And finally, there's also what seems maybe a bit more islands, like separate factors such as hearing impairment and air pollution. I haven't mentioned them all again. There's great, these reports, require deep study, and we could talk the whole hour about this, but we're moving on. Is there any medication to cure or slow dementia? So at the moment, there's no scientific evidence that any pharmacological treatment can delay, prevent, cure, or slow down the effects or the dementia themselves. Despite some huge media campaigns, I'll show you one later in the second lecture. Unfortunately, there's sometimes huge media campaigns that now that we have a breakthrough. And the importance for us as professionals is to maybe celebrate a little bit, but then look at the studies that have been done and read all the small print. And I'll give you an example of this later. What I can say that there are some medications that work for some people at some point for specific symptoms, but so there's not an overall pharmacological treatments that would be helpful. So what can someone do when they have dementia, or what can you as a professional recommend them? Again, this is almost the whole focus of the second lecture, but just to touch on it again. The best summary statement I have ever seen was a campaign around 10 years ago from Dementia Australia, and they recommended people to stay active, both physically, cognitively, so brain activity, as well as socially. So all these three components are really important. I think this is my final question. So what can you do as a professional, or if you are a caregiver for a family member who has dementia? I think it all starts with developing the awareness. So we're well on our way today. And then whenever you encounter somebody who has the symptoms often are gradual, but by the time they get recognized or they become visible, they can look a little bit acute. So the report of the person themselves or their family will be, all of a sudden, they cannot do this and this. So when it's a sudden change, but it is persistent over time, and the changes, we're talking obviously about brain functioning. So when it's a sudden change that doesn't change back, dementia could be something you can start considering for regularly for people over 65, but also under that age. Again, that's very rare, but it's not impossible. So you can always keep it in the back of your mind. From there, you may, we talk about this again a bit more, the diagnosis stage, but I think from the start, what happens quite often, also because for medical doctors, this is your profession, you treat diseases. But with dementia especially, it's so important to circle back to the person, because unfortunately, dementia does not present in one way. Every person looks different from each other and may even fluctuate between days. So it is really hard to diagnose because there is not a profile of, okay, this is what a person with dementia looks like. The second recommendation would be to start working with developing possibilities instead of kind of trying to reverse the limitation. Sometimes that's possible, but I think what happens is dementia is such well, sorry for the pun, it's not, but it's a confusing diagnosis that throws off a lot of people and kind of forces people, or naturally makes people focus on all the losses, all the things the person can't do anymore. And this is natural. We need to have this process of grief. However, it makes us feel very stuck. Whereas there's so many things possible that once we may want to combine the two, that there is space for grief and sadness about what is lost. But at the same time, we start looking at, okay, but what is still possible? And that's where the space is for the people themselves, their families, and us as professionals. We can do this through non-pharmacological interventions and adaptations of social and physical environment. And I'll talk about that in lecture 2 today. Let's zoom in on normal aging, mild cognitive impairment, and dementia. So yeah, some of my text is covered. Yeah, I can move that. Great. So normal aging, let's focus on that first. Even with normal aging, the brain capacity and functioning will change. This is just an actual fact. Again, it can change to a different extent between people at different ages as well. And as I already mentioned, for people with dementia, this is true for all of us. Our functioning, our cognitive functioning and other types of functioning, it will fluctuate between days. And in the case of cognitive brain functioning, it can fluctuate with how much sleep you had. If you're sleep deprived, you might actually be more forgetful or have less focus, less concentration. Hormonal cycles in both men and women are really important. And I think a really pronounced example of this is actually called pregnancy dementia. If you have been pregnant, you may have experienced bouts of memory loss, and even sometimes in the middle of a conversation, absolutely not remembering what you were just talking about. And stress can also really impact how we function. Generally speaking, when we age, learning new skills can be more difficult or take more time. And for example, this can result in problems with finding objects or remembering names. And my note at the bottom, so brain plasticity is the capacity of our brain to actually work around any problems it encounters. So even when we have mild cognitive impairments, the brain might initially work very hard to work around the area that is impaired, and it has a great capacity to actually find detours and different ways to still keep functioning. So the more we train our brain plasticity, you can see it as a muscle. The more we train it, the better we are prepared for changes in the future. And it really, really follows that use it or lose it principle. And that brings me to the next point. Hang on, is that working? Yes. Once we're like 60, 70 years old of age, we often, and this can happen earlier in life also, but we may have decades or even lifelong routines and habits. You know, we just found the way we're most comfortable with. You can even think of how do you get to work. Most people will go to work using the exact same road every day, unless they've seen on the map that it's really congested, and then they take the second route that is always their backup route. That's just a tiny example, but you can observe yourself that throughout your day, you do things in a specific way. And especially when we have a lot going on in our lives, it makes perfect sense. However, this reduces our brain plasticity, which would then lead to less flexibility and less creativity. So this is all still normal aging. If we then shift to mild cognitive impairments, so for normal aging, you can still say, okay, sometimes misplacing your keys, that can happen. Sometimes forgetting a name of a person, it can happen. But if symptoms become more frequent or very persistent, then we start thinking about mild cognitive impairment. And this can be a transitional stage between normal aging and then developing dementia. I have to mention only 10 or 20% of those aged 85 and over with MCI go on to develop dementia. And just one of the sentences that really helps me to understand the difference between, hey, this is a person who's aging normally versus now I have to start thinking of MCI or maybe even dementia is when somebody cannot find their keys, that doesn't imply that they might have dementia. A better indicator is that when they actually find their keys, but they don't know what to do with them, that is more problematic. And I just mentioned that, you know, forgetting a name of a person and maybe even a loved one can occur with age. However, if this is very consistent, and especially of people that are really close, like a spouse, children, grandchildren, you can get a little bit more suspicious, but it's even more a better indicator if they don't know what the relationship is to the person. So for example, if they start referring to their daughter as their wife or even their mother, that's usually again where we start thinking, look, this might not be normal aging, but something else is going on. Now moving, so normal aging we leave behind for a moment, moving into the differences between mild cognitive impairment and dementia. So we call it mild cognitive impairment when only one brain function is impaired. So you could think about changes in memory, so forgetfulness, or changes in concentration, focus, or changes in language, or in thinking, or in judgment. So when it's only one, we only call it MCI. Like I said, only 10 to 20% of people who have this will develop into mild dementia. Some people will fully recover from MCI, and some people just stay in that stage of MCI. So they'll have that one domain that is impaired in the course of their life. The minute that we move into mild dementia, that's when 2 or more brain functions are impaired. So you start to see combination of a person who is very forgetful, has problems with logical thinking, and also has problems with their speech. Just as a kind of a metaphor that might help you to memorize this. So if we imagine our brain as a network, a sophisticated network of roads, which are your neural pathways, and then a lot of traffic, which is your neural messaging. If we look at normal aging, it's basically the normal aging of the brain looks like normal aging of our roads. So if we don't maintain our roads, obviously there's going to be minor erosion of the network over time. Our capacity for maintenance may start running behind a little bit, and we'll have some congested areas, which means, you know, there's traffic where in Machet we can't move. But usually at some point this will be relieved and the road opens. When we then described MCI in this metaphor, it basically means that one branch of roads is now completely congested. So it's full of traffic, nobody's moving. Or the other description could be, look, this network of roads is actually crumbled, is falling apart. And so this function that relies on these roads is now impaired. If we then look at dementia, it means that many of the road clusters are affected. The axis becomes totally blocked. The brain plasticity isn't there to circumvent any of the blockages, and it becomes increasingly difficult to construct new roads as well. And this is what it could look like on a scan. So on the left side, you see a healthy functioning brain. The brighter the colors, the more activity. I'm sure you're familiar with this. Then we look at the middle, you see that, you know, the red and the yellow is somewhat reduced. And there's mainly more green, so not yet so much of the blue to black, which means inactivity. And on your right-hand side, you see someone with, I would say, quite severe Alzheimer's dementia, and you see whole areas of the brain that are no longer active, unfortunately. All right. That was the introduction of the differences between normal aging, MCI, and dementia. We're now going to focus in on dementia and talk about what types of dementia. I'm only choosing the most prevalent ones. The common name is actually, and this is one of the things where I am sharing my opinion, my preference. Usually all these diseases are called diseases. Alzheimer's disease, vascular dementia. Some of them are called dementia, but I very constantly choose to also label Alzheimer's as dementia or Alzheimer's as a syndrome. And that's just, it's almost a tactical choice that the minute we are talking about disease, it becomes something very big. And especially a brain disease seems like a hurdle that is very hard to tackle. The minute we describe it as what it is, dementia, or we even move to syndrome, we kind of lower the bar a bit. I'll talk about this again a little bit later. And I also want to say the types and the causes of dementia. So why do I put both? Frequently, all these types that you see on your screen, they are described as this is a form of dementia. However, I have defined dementia as brain damage, which means that these things is what is underlying the dementia. That's why I call them causes. Let's start with Alzheimer's dementia, which is usually diagnosed when people present with dementia. So 60 to 70% of the diagnoses of dementia are then placed under the Alzheimer's types. It was first discovered in the 1890s. You'll see that most dementias were discovered at that time. So there clearly was something happening, probably better tools to actually look at the brain. As I said, this is the most common form in that it's diagnosed the most often. We're starting to shift more and more towards thinking that it's actually mixed dementia that I will describe in a moment that might be more prevalent. And the reason that we actually don't know is that we can only diagnose people post-mortem. So when we can have a look at the brain, we can actually see what's going on. And this makes it challenging for us as professionals. However, just having this knowledge will help us in our diagnosis process, but maybe also how we communicate about dementia. Maybe with less certainty that, we are used to. A broken leg is often just a broken leg. The story is different for dementia. Most visible symptoms you will start to see at the age of 65. Could be a little bit younger in Indonesia. We could start saying from maybe 60 and up. But there's also something called early onset Alzheimer's, which could occur at age 30, 40, 50. It's extremely rare, but it does exist. And this is not my expertise at all, but just to share with you the physiological presentation that could be seen after the person has passed away is abnormal amounts of amyloid beta, amyloid plaques, and tau proteins in the brain. So that's how we can establish, okay, the cause is Alzheimer's disease. What you can see on your brain scans is actually, and I'll go back just for a moment, a shrinking of the brain. You can't really see that much here, but usually it's really as it, when you have a dried out nut, it just shrinks in size. That's what happens. But what you can see really well here on the right-hand side is the expansion of the ventricles, the gaps between brain matter. And that's, for your diagnostics, the helpful things when you're looking for Alzheimer's disease. I've shared most of that. The main symptoms that you will notice, or usually are noticed by family members first and foremost, are forgetfulness and memory issues. This would be your primary symptom. But then also concentration, focus, language problems, both hearing or speaking, emotional and personality changes. And for the other types of dementia, you'll see that the emphasis is actually on some of those symptoms. But so in dementia, Alzheimer's, you will be mostly looking for that forgetfulness and then mapping all the other symptoms as well. It is a low but steady decrease of functioning over time if we don't put any interventions in place. This is what Alzheimer's Indonesia has published a couple of years back already. I'll just leave it on the screen for a moment so that you can have a read or a look. And I'll slowly talk you through it. So these are the 10 signs, the 10 warning signs of Alzheimer's, as seen as most important here in Indonesia. So the first one, like I also just mentioned, would be memory impairment and forgetfulness. The second one is problems with focusing. So a person forgets what they were doing. The third one, difficulty with performing familiar activities. That could actually be one that is quite easily recognizable, that all of a sudden a person is at a loss doing something that they've done for decades. That's a big red flag. We have disorientation in place and time. A lot of the diagnostic measures will ask the person, what's the year, what's the date, what's the day of the week. And you'll see that people start struggling with that, or they forget where they are, or maybe in their familiar area, it will be still okay to get around. But if you would put them in an area of their city that they're not familiar with, it might be really easy to just completely get disoriented and not understand how to get around. There's trouble with, or there's potential trouble with processing spatial information. So, how things are placed in relation to each other. It's quite likely that the person, especially in later stages, starts having a communication impairment. They may be misplacing objects. They may have problems solving any challenges, problem solving issues. They might start withdrawing from social interactions. And I think, again, in Indonesia, this could be one of the ones that is recognized quite early, because this is such a family-based, community-based society where there's a lot of social interaction coming together. And the minute when a person has always attended those meetings, but the minute they start withdrawing, and they might say to their family member or to you, it's just so overwhelming. There's so much going on. That is, again, a huge indication, a huge red flag that they might be having dementia. Yeah, that's what I wanted to say. And the last one, as mentioned also just before, is behavioral and personality changes. Let's move to vascular dementia, the second most prevalent type of dementia, also discovered by Dr. Alzheimer in collaboration with Dr. Biswanger, again in the 1890s. And it was previously described as brain congestion, and that included things such as stroke, anxiety, and cognitive decline. We now know that vascular dementia develops from a lack of blood in certain areas of the brain. So possible causes are blood clots, high blood pressure, TIAs, or strokes, mini strokes. And the symptoms obviously depend on which area has been deprived of blood. So again, it can look very different between individuals. The NHS from the UK has described early signs of vascular dementia as slowness of thought, difficulty planning, trouble understanding, problems with concentrations, changes to mood and behavior, and problems with memory and language. And as you see, memory problems are placed quite to the bottom here. So that would be one of the first differences between Alzheimer's disease and vascular disease, that where memory problems are very central in Alzheimer's, they're not as central, but they may occur with vascular as well. I think the biggest indication for us as clinicians to look at the difference between the two is the progressions of symptoms. So what you see here is the blue line would be somebody who has Alzheimer's dementia, and on the axis you see the years, and I just made it a scale from 0 to 10 on their brain functioning. And as you can see over the years, there's just a steady decline every year, a little bit. And so they start at 0.10, and after a good 5-6 years, they are now at level 5. The difference with vascular dementia is that vascular dementia worsens, or the symptoms worsens, when there is an issue, an incident, like a mini stroke, a TIA. So if we follow the person in yellow in 2021, their functioning is at a 10. They have an incident and their functioning drops down to 9. However, for the next 2 years, they remain at the level of 9 because they don't have any other incidents. Unfortunately, in 2024, they have another brain incident and the functioning drops again. So as a clinician, this could be something to be really on the lookout for. Like, do I see a steady decline, or was there a huge drop in functioning, but now they're staying at the same level? The third most common type of dementia is Lewy body dementia. We are now talking about 5 to 10% of all dementias diagnosed. And again, this is an estimation. This was discovered by Dr. Lewy a little bit later than the other dementias. And again, what it looks like in the brain is a build-up of excessive Lewy bodies in the brain. This is an alpha-synuclein protein, which the function actually is not really known of. The Lewy bodies aren't a problem in itself, it's that excessive accumulation that starts causing problems in the brain. Like vascular dementia and frontotemporal dementia that I will discuss next, for these types of dementia, memory loss is not at the center of it, like it is for Alzheimer's. So let's look at some symptoms for Lewy body dementia. It's quite a different package of symptoms, and it might steer you much more to the psychiatric disorders that you know. So you can think of delusions, ideas that are not grounded in reality. Specifically visual hallucinations, so seeing things that the people around them are not seeing. Any disturbances in sleep, changes in thinking, reasoning, trouble interpreting visual information, problems with the whole autonomic nervous system, some confusion, and also symptoms that kind of are similar to Parkinson. I will discuss Parkinson's dementia again later on, but if you see a slowness and gait imbalance, it could point to Parkinson, but it could also point to Lewy body dementia. These are closely related to each other. So if I compare Lewy body to Alzheimer's and vascular, what it has in common with Alzheimer's is that the symptoms here are progressive. So you see that steady decline again. However, the onset is earlier than in Alzheimer's disease, but not commonly for before the age of 50. But so if you have a person who presents with some of those symptoms between the age of 50 and 60, you might consider Lewy body dementia alongside Alzheimer's, early onset Alzheimer's dementia. Alzheimer's is more common in female. Lewy body, however, is more common in males. So that could be, again, another thing to look out for. Who do you have sitting in front of you? So memory loss is not at the core of the changes, but it may remind you of like schizophrenia or psychiatric syndromes, as I mentioned before. The fourth type of dementia is frontotemporal dementia. This is a very helpful name because it actually describes to us where the problems are located. So it's both the frontal lobe as well as both temporal lobes. It was previously known as Pick disease and also discovered in the 1890s, but by Dr. Pick. It occurs at quite a younger age than most of the other three I just discussed. So you can start thinking about people even in their 40s, their 50s and 60s. And again, the center of this problem, this dementia, is not really memory problems. So this is much more related to personality and behavior, which is when the frontal lobe is impacted, and our language center, which is in our temporal lobe. So they can start having really trouble expressing themselves or understanding language as well. So the most pronounced symptoms for FTD are expressing or dealing with emotions, struggling to speak or understand speech, and then behavioral changes. And specifically and quite unfortunately, it often presents as very inappropriate behavior. So you could think of cursing, oversharing, commenting rudely. It's probably a little bit over the top to say, but if a person always has been a bit coarse, this might not be a symptom. So it's especially important, again, that we're looking at the changes in functioning. So if somebody has always been very gentle or very polite and now starts blurting out things that are just not appropriate, it's a huge indicator that we might be looking at FTD. There's a couple of subtypes, but for the sake of time, I'm gonna proceed here. Comparing frontotemporal to AD and VD. So again, like Alzheimer's, the symptoms of frontotemporal are progressive. They start at a much earlier age though, so even much earlier than the Lewy body variant. It can be as early as in somebody's 20s. And only specific areas, like I said, are impacted. I think I've shared that. Moving into Parkinson's related dementia. So Parkinson's is a syndrome, neurodegenerative syndrome in itself. However, in later stages of Parkinson's disease, it can be accompanied by dementia. The description of just Parkinson's just Parkinson's disease is that it affects the dopamine producing neurons only in the substantia nigra, which is a place in the brain. And again, and this is what it has in common with Lewy body dementia, it's a buildup of Lewy bodies, but only in this specific brain area. The symptoms build up slowly over the year. And usually the first thing you'll see is that people start having trouble with mobility. So they may start moving slower. The gait and the balance might have problems. It's quite indicative that people start taking very small steps because they can become quite afraid of falling. So they start taking, it look like shuffling. And then limbs can also become quite stiff. And I'm sure you're also familiar with the tremors that present or are very visible in the hands. So as I said, in the later stages, people with Parkinson's can have dementia symptoms, and there could be a good 10 years between actually having Parkinson's symptoms to then developing Parkinson's-related dementia. And not everybody gets it, so the Alzheimer's Association estimated that 50 to 80% of those with Parkinson's will experience dementia later on. And the risk factors within people who already have Parkinson's to then go on and develop dementia are advanced age, severe motor symptoms, the presence of MCI, as well as excessive daytime sleeping, hallucinations, and postural instability and gait disturbances. So again, these could be indicators for us as professionals that, okay, I have a person who has Parkinson's, and all these indicators are there. I should be really on the lookout for symptoms of dementia as well. The next type is basically integrating the first 4 types. It's called mixed dementia. And as I said before, this is probably the most prevalent form of dementia. It just means that the brain is changing because of 2 or more of the causes I just described. The most common combination is Alzheimer's disease with vascular disease. So I'm reprinting here the graph of the person with Alzheimer's in blue, in yellow, the person who has vascular dementia, and now I've added a person in purple who has both. So you see a constant decline over time, but then in the year 2022 and 2024, you see much more significant drops because of cardiovascular incidents. So yeah, that's what that would look like. The second most common type of mixed dementia would be Alzheimer's disease with Lewy body. I mentioned this before, so only autopsies reveal which type of dementia we're dealing with. And NIA study has reported that during life, around 94% of the dementias are diagnosed as Alzheimer's dementia. However, of those, 54% turned out to actually be mixed dementia. So post-mortem, they established, okay, half of these people actually had a mixed dementia, had more than one thing happening in their brain. I feel this is really important, even though, you know, we can't do anything about only having this knowledge post-mortem, but we can incorporate this knowledge into the information provision to our patients as well as our own treatment plan, that we always need to consider that we're doing our best to diagnose, but we cannot have the full picture. The final type I would like to discuss with you is Huntington's. This is quite different from all the other ones, but it's very impactful, and you may encounter it in your practice. The difference is that it is fully hereditary, which means that every child of a parent with Huntington's dementia has a 50% chance of developing it themselves. There's tests available, and there's a huge discussion among people with Huntington's themselves. Should they get tested or not? Some people just obviously want to have the information, but the problem is that there's not a very good treatment. So what do you then do with your knowledge? It is, well, and I know you encounter this with other patients as well, that, what do we do the moment that we can test you, but we have nothing available to then help you? This is a very philosophical discussion that maybe we can all have with ourselves. Unfortunately, I don't have enough time. It affects the whole nervous system, so spinal cord and brain as well, both men and women, and it presents between the ages of 30 and 50. Some people get it much younger, under the age of 20, which we call juvenile ADHD, which is very rare, only 10% of all cases. The juvenile variant also presents quite differently in that it affects movement, learning, thinking, and emotions, whereas the non-juvenile, so the presentation of symptoms between the age of 30 and 50, you're much more looking still at problems with movement, but mainly also cognition and behavioral symptoms. It is a gradual progression with a huge variety between individuals. So even within one family, it can present very differently between the different individuals. And one of the most visible and impairing symptoms of this type of dementia is that people start lashing out with their limbs, kicking with the legs, or slapping with the arms, which is sudden and unexpected, and clearly is very hard to deal with, to function with. Those were all the types or causes of dementia I wanted to talk you through today. Let's zoom out just a little bit more towards, okay, what do we consider when we're trying to diagnose someone with dementia? So the first thing to remember, I think, is that there are so many different causes, and that we can start with testing for any infections, stress and fatigue that are prolonged and not just temporary, hormonal fluctuations, and also, is there been any recent head trauma, any accidents, any falls? So we start ruling those out as the possible causes of things that look like dementia. Really important for women in midlife, perimenopausal symptoms, which can start as early as the late 30s, definitely in the 40s and 50s. But some of these can look like MCI or dementia as well. So the age and the gender of the person in front of you are super important in, are we going down the dementia road, or are we considering perimenopausal symptoms for this person as well? And the same goes for severe stress and burnout. Some of these look very, very similar to dementias. So there's a lot of work to do, right? Again, as I said before, when somebody presents with a fractured leg, the fracture can still look different, but it's pretty obvious what we're dealing with. And unfortunately, with dementia, it is much, much less obvious. So we also definitely need to consider other psychiatric syndromes, especially for Lewy body, as I mentioned. You could think of schizophrenia, and the opposite, when you have somebody with schizophrenia who's maybe aging and maybe the symptoms are getting worse and worse, you could start looking at Lewy body as well. And then there's depression, which has a very intricate relationship with dementia that definitely deserves a couple of slides by itself. So if we talk about major depressive disorder, MDD, it affects around 70% of the general adult population. It can very, very much, the symptoms can be mild to severe. Some people have acute episodes. Some people have acute episodes that then alternate with manic periods where they're much more active. It's almost two opposites. That's why it's called bipolar. And some people will have very mild symptoms of depression, but they are chronic. So they just have a slight drop in mood, but it doesn't really ever lift. So again, like the dementia, MDD, depression can look very, very different between persons and within persons between days. This is the description from the DSM-5 for major depressive disorder. So the person could have some of the following symptoms: feeling sad or having depressed mood, loss of interest or joy in normal activities, change in appetite, weight loss or weight gain. So here you go. It could be weight loss, it could be weight gain. It could be trouble sleeping or oversleeping. So all these opposites might indicate the same thing. A loss of energy, a severe fatigue, increase in purposeless physical activities, feelings of worthlessness or guilt, difficulty thinking, concentrating, making decisions, and thoughts of death and suicide. I've highlighted the ones that are very similar to dementia in bold. So the loss of interest is very common. Problems sleeping, especially in certain subtypes of dementia, can be very common. And obviously the difficulty thinking and concentrating and decision making is almost one-on-one. So you can see why you would get confused between the two. Another problem with depression, before comparing it more to dementia, is that it's quite hard to recognize in older people just because of some of the changes that occur with normal aging again. So first of all, older people often need less sleep anyway. They might wake up rather early. When people stop working, first of all, that can disrupt their orientation in time, and also their structure might be completely wiped out, and it could present with feelings of worthlessness or sadness. Physical impairments could lead to decreased activities. Weight loss, especially of muscle mass, is rather common, and older generations may, generally speaking, be less prone to expressing emotions, which, naming that I feel sad or down or depressed might just not be something they will do. So when we look at MDD in older age, we might not just necessarily want to look for symptoms of sadness, but much more at that lack of initiation or enjoyment of their activities. Now, this is more about the intricate relationship between depression and dementia. They can co-occur at different stages of dementia. So for example, when receiving a diagnosis of dementia, it happens that people will actually develop a depression just because of the sheer message they receive and the helplessness they experience. Unfortunately, quite often people are told you have dementia and there's nothing we can do. So that's where that helplessness comes from. MDD can occur when the symptoms of dementia get worse over time, and maybe somebody loses functions that were really essential to them. It can also occur when people are moved out of their familiar environment into the house of, for example, children, which can be a really good idea because of more familial support. However, moving somebody at that age and that stage of their life can cause a lot of extra confusion and also may lead to less independence, which could be problematic as well. In that Lancet Commission report about risk factors for developing dementia, major depression disorder is actually one of the risk factors. If you have it in midlife, your chances of developing dementia later in life increase. So this is just to show that, it can follow from dementia. However, it can also be a risk factor for dementia. It can be very hard to distinguish what came first and also what your primary diagnosis should be, because just major depression in itself can present with confusion and forgetfulness. So I think it's really important to take away from what I'm trying to say that once a person has dementia or depression, you need to closely monitor the other as well. Then a comparison with delirium. You're probably much more familiar with people with deliriums than I am. It happens a lot in hospital settings, obviously. It's often confused with dementia. The big differences are that it has a very quick onset, the memory loss and forgetfulness. It's days, if not hours. And also, if treated well, it is reversible, which is kind of hopeful, isn't it? Delirium can follow from poor lifestyle choices such as alcohol abuse, malnutrition, dehydration, sleep deprivation, as well as certain diseases and medications. And a really important thing to highlight that once a person has dementia, they're much more at risk of having deliriums on top of them. And again, almost like vascular dementia, the minute a person with dementia gets a delirium and it isn't treated properly, you're going to see a huge drop in their functioning because it just impairs them so much. When we're investigating if somebody has dementia, we should consider if they're not in a delirium. And on the other side of the spectrum, once people have been diagnosed with dementia, we should definitely be on the lookout for the risk of them developing deliriums. If responded to very quickly and appropriately, so for example, it's caused by dehydration and we up their fluids, it could potentially completely reverse all the symptoms you saw of a delirium. And especially highlighting this again, that hospital admissions unfortunately can trigger deliriums in itself. Again, for that reason that we've taken people out of their familiar environment. They may feel very disoriented. Where are we? What are we doing? They may feel confused, and there's always a risk of infections that is a bit higher than the risk at home. What does it look like? So again, these are acute systems that may just appear on the spot. A very reduced awareness of the environment, so they could be having trouble responding to your questions, having a conversation in general, and they could be either easily distracted, there's a more active form of delirium, or more withdrawn, there's also a hypo form of delirium. Cognitive impairments as well, so there's your confusion with dementia, so any memory loss for recent events, usually leading up to hospitalization or seeing a doctor. So probably a family member or a loved one can tell you that there were some really distressing event involving those hallucinations or delusions described as well. But the person cannot recall any of it. They will be disoriented and have problems with communicating. And like I just said, it often presents with hallucinations, delusions, restlessness, agitation, or even aggression. And that's all mainly for the more hyper variant. When a person has the hypo variant, they are often just very withdrawn and unresponsive. So again, two opposites pointing to a similar diagnosis. And sleep disturbances and emotional changes could also be an indication. The symptoms keep fluctuating, so, and even the personality can look completely different. They might not be recognized by their loved ones. I think I touched on most of this. So there's a hyperactive form, which has more activity, and a hypoactive, which is more withdrawn. You can also have a mixed delirium where people alternate between the two. So maybe Dr. Krishna, can you give me an indication of how much time I have left?
Still 10 minutes to go.
Okay, great. I think I speed up a little bit. So why and how do I diagnose dementia? And I think I've highlighted it enough, but these syndromes all present so differently that The only thing I can recommend from my experience is to look for symptoms related to brain functioning that have rather suddenly and persistently changed and are out of the ordinary for that individual. That should be a red flag for you. That being said, if somebody has never expressed emotions, this cannot be seen as a core symptom. If they were never really good at remembering people's names or who they were, again, these are not in it. So that second part of my sentence, they are out of the ordinary. That is really important. For me, at the stage I'm in with doing this work, I actually prefer to focus on the symptoms versus getting a diagnosis. Still, getting a diagnosis is very important, especially for the people who have the symptoms, and maybe even more so for their family members. It really helps people to understand and to have a name for it. It just brings quite a relief, even though they might not know how to go from there. But there will be that sense of, well, finally, people quite often say, see, I'm not crazy. Something was changing in my loved one or in myself. One of the things that I find very important when diagnosis, and this is, again, this is my personal opinion, and you might feel very different. And I don't think it's very common for medical doctors to do this, but to start sharing your uncertainty and to, for example, say, look, based on your symptoms and the age that you are or the age that this started, it is likely that you have Alzheimer's disease. However, research has shown that this is not a definite diagnosis. Or another one could be, look, we think you have Alzheimer's disease, but the trajectory, the symptoms, your progression over time is never the same between two people. Now, I really, really understand that this uncertainty can actually cause further confusion and fear in the person you're talking to. However, we can also flip that over and start seeing that maybe there's hope in this message, because it is not, as I shared before, that, you have dementia, there's nothing we can do. This is not true. And that's the whole second lecture. We'll start talking about what we can do. So, people with dementia aren't doomed. There's not a progression that cannot be stopped. We can put things in place. We can adapt the environment. So it could be a message of hope to say, look, we think you have this. We're not entirely certain, and we can definitely not tell you a whole lot on what happens, but let's start talking about the symptoms you have today, and we monitor them over time. That's exactly the second point on my slide, so I'll skip that. So the reason for me to start focusing in on symptoms is basically a question. What can we do about the diagnosis of Alzheimer's dementia? It's like the Himalayas, the largest, the Mount Everest of problems, right? You have dementia, now what? How are we going to climb that mountain? And it's just too much at the same time. However, when we start looking at a symptom, and I put the example on the slide of, okay, somebody has started to forget to turn off the gas when they're cooking. This is dangerous. There's no doubt about it. However, we can do something about the system. There are safety switches that we can use. We can start cooking on electric plates. We can start cooking together, or we can ask the person to just do the preparation and another person does the cooking. So the minute we start focusing in on symptoms, we start looking at interventions, possibilities. This is where we can make the change. I want to make an Indonesia specific note. We did an interesting study, if I may say so myself, with Dr. Shredder Butterfield and Dr. Handayani from the Jakarta Atmajaya University. And we looked at how is dementia talked about in Indonesian communities. And it was really interesting because there were some really things that are so specific for your beautiful country. And the thing is, dementia is not recognized early. I see this as a strength because what it meant is that as long as people were functioning relatively normal, maybe a little bit forgetful or a little bit strange at times, but when they functioned relatively normal, they would remain in the community and they would maintain their usual activities. And these are the things that in, say, Europe or the Netherlands, we're actually trying to reinstall. We want people to be part of the community and to function normally, because that's when we can stop or reverse some of the symptoms. The sadder message is that the minute the dementia starts to really show and people start having behaviors that are quite out of the ordinary, could be even aggressive or erratic, then unfortunately within this society, the measures that are taken are quite extreme, such as completely taking over any activities, and even locking people behind closed doors. Unfortunately, we heard that on more than one occasion. The implications for you of this study is that you should realize that you'll usually only see people with rather advanced dementia, just because they're still functioning in the beginning stages. I don't think it's a problem. I think it's beautiful, but it does mean that people will come to you when they're rather far in the trajectory, and you'll have more complexity, more symptoms, and they may look irreversible. If you are interested in finding people in the earlier stages of dementia, because the more we do at the earlier stages, the less we might need to do later if we can help them function independently, you might really start to think about actively doing home visits. I know at some areas in Indonesia, the puskesmas will do this. They will knock on people's doors and talk to them. If you have a cognitive, I wouldn't necessarily do a measure, but just teach the people who do these home visits to be on the lookout for cognitive changes. Could be such an indication for us as professionals to go and visit this person and see what's going on. Especially at risk are people that we call care avoiders. So they're not coming to visit you. For older people, this can often imply that something is seriously wrong. They're just not ready to face it. And it's a fine balance between respecting the person, but also going, no, we can really seriously help you without any intrusions. So we come look for you and see if you allow us. And also, unfortunately, people who are living alone without family members. Let me see. Just the stigma. This will be my last part for this first lecture. I do really want to highlight this, so I hope it's okay. I might take 5 minutes longer than agreed. There's so much stigma around dementia. And I'm now zooming out. I'm not talking particularly about the Indonesian situation. This is a global problem. In more individualistic society, it's very easy for older people to become isolated, especially those with MCI and dementia. So this is a global problem. I think when we think of stigma, it's quite hard, it's quite confrontational, isn't it? But it can present very subtly. So we may go, no, I'm not ageist, I don't discriminate, I'm very inclusive. But for people with dementia, this is what stigma could look like as well. First of all, again, we see this very frequently. We start talking about the person with dementia. Over their heads, they're in the same room, and we forget to ask them the most basic things. And yet they're sitting there while, for example, me and the spouse are discussing them. I think not for a minute you should underestimate the effect. Even if they look withdrawn, unresponsive, they probably know what's going on. I mentioned this before, that when things get hazardous, we might decide to immediately, without a second chance, just take over and take away these activities. Of course, in terms of safety, it is wise. However, we kind of push the person into deteriorating faster if we take away their activities. Again, second lecture, we talk more about how can we keep them active? What do we do how do we keep them involved? Because involvement, independence, means slower deterioration. Another form of stigma could be spoken to in very simple language, or a repetitive language, or a very loud voice. Again, I've seen this on many, many more occasions. Being mocked or teased, or isolating them as well. Another form could be no longer listening or responding when they keep asking the same questions or keep telling the same stories. I'm not saying you have to sit through it every single time, but we could at least go through a process where we try to find out where this is coming from. Why do they ask these questions? What is the underlying assumption or anxiety? And sometimes Maria Montessori, who I will talk about in the second lecture, says repeated questions could be an indication of trying to keep a loved one close. So you may feel annoyed with the questions, whereas this is their way of trying to keep you close as their safety. All right. I think eliminate the stigma in Indonesia, but also worldwide. It all starts with creating awareness of that this does exist. It is not a one size fits all. It looks very different in different people. Some of the core symptoms you can look at are these, and these. A second step is, and I also recommended it for us as professionals, try not to zoom in on the diagnosis, the disease. The person still remains a person with their whole character, their whole history, because people are often at an advanced age. They carry so much luggage and stories and experiences. And again, one of the, for me, the positive things in Indonesia is that we actually celebrate older people. So that is something to also to keep doing when people have these problems. And even the words we use can really change the narrative. So in English, there's often mention, especially in popular media, of the demented, as if the person has become the disease. So we can change that to people with dementia. I before shared that I don't want to speak about Alzheimer's disease, but I want to speak about Alzheimer's syndrome. The same like Down syndrome, where the focus is on inclusion and integration. That's what I want to work towards for Alzheimer's as well. And then we have BPSD, behavioral psychological symptoms of dementia, and neurological symptoms of dementia, which just put you in this circle of the person has these behaviors because they have dementia. How do I know they have dementia? Because they have these behaviors. I want to shift towards using the word misunderstood behavior, which then makes us an actor. I'll stop here. Oh, wow. Well, I was supposed to stop here. There's more to be said about this, and some of this will be discussed in the second lecture as well. So let's open the floor for some questions, I believe.
Okay, thank you, Dr. Eva, for your great presentation. We have two questions in the chat. So the first question is from Dr. Andika. Uh, the question is, uh, in qualitative research involving people with dementia, how can researchers ensure that patient life experience and perspective are represented as accurately and authentically as possible, given their memory and cognitive impairment, without relying too heavily on caregivers' narrative? Are there any specific methodological approach or strategies you would recommend to enhance the credibility and trustworthiness of the data?
Well, thank you so
Yeah.
much for this question. I'm
Hmm.
smiling broadly because this is so important. Because you're absolutely right that we tend to focus on the narratives of the families, which are colored by their experiences and their hopes and losses and fears. There's a lot of diagnostic questionnaires out there. I mentioned them before. They will ask about what's the year, what's the day of the week, where are we? These can be important. I'm not the biggest fan, again, very personal, because they feel very much like a test. So I would like to steer more. There's a a questionnaire that is called the Clinical Dementia Rating, the CDR. It is more of an interview, it's more of a conversation. That could be a tool to use. You speak both to the person themselves and then to the primary family caregiver, and you have to, as a clinician, integrate that information. Sorry, the order is different. You first talk to their informant and then you speak to the person themselves. However, my favorite way is observations. Obviously, there are some downsides because all of a sudden there's a person sitting there. Maybe with technology we can even eliminate the person, but also if a person spends significant time, they might blend in a little bit better into the background. I'm going to be presenting a couple of studies in the second lecture, but what we did was observe engagement, behaviors. So we would choose one behavior, and you just choose the behavior for that person that is most prevalent for that person. In our population, I'll explain more later, so a little bit of a shortcut. But most people would wander around. They would pace up and down the room. So you could just observe behaviors like that. And then if you do an intervention, you could see if these behaviors change. You could look at engagement. How is the person engaged in what they're supposed to be doing? And you can also observe their effect. We had a huge learning curve with observing effect because obviously you mainly look at a person's visual expression. In our first study, we would note it for every minute if a person looked joyful, angry, sad, neutral. Turned out, and they had to be like angry for half a minute to be scored as angry. This time frame was way too long. So we really learned very quickly that expressions of joy, but also of anger, they're very short. So you want to look at maybe counting, okay, how often does the person have a genuine smile or laughs out loud? How often do they have angry outbursts? And how far is that out of the ordinary for this person? So I think, and it really fits in with the purpose of this course, that we really want to move towards observing people in their natural environment. And my last addition would be, and that goes back to my little spiel about stigma, I would always suggest to ask the person with dementia first. And there are different ways of asking the same question. So if you want to have an indication, what would they like to do today? That question alone is often way too big for a person with dementia, but we can start giving them options. So in my opinion, we should first and foremost go to the person themselves. One of my mentors, Dr. Cameron Gam, had a little bit funny examples that he had a highly intelligent resident who I believe was a professor in psychiatry, and he had now dementia. And he started having the habit of urinating in the plants. And the staff got very, very stressed. Why is he doing it? It smells, it's dirty. And they called in Cameron, my mentor, and he just went up to the man and he said, "Well, sir, I hear you've been doing this. Is that true?" He said, "Yeah." He admitted it, really. "Yes." And Cameron said, "Well, why are you doing this?" And he said, "Well, they think I'm crazy. I give them crazy." Nobody could have guessed this, right? That this highly intelligent man with certain symptoms could still be so fluent in expressing, "Look, I know I'm doing this, and this is the reason." So to ask the person themselves. I have an example I really like, if I still can, Dr. Krishna. That goes back to that misunderstood behavior. I was working with a man who at certain times of day would start moving around all the furniture. He was living in a facility with other people, and you have a common room, and he would start dragging the chairs and the tables. And the noise, because these floors, they're not soft, so it's screeching noises of him doing this, agitating everyone. And clearly, when you look at him, you think this man is not in his right mind until you ask him, "Well, what are you doing, Eddie?" And this man used to be a motor mechanic, automobile mechanic. And he said, I'm preparing my workplace. So he was in an environment that didn't stimulate him at all. And he was just looking for something to do. Now, if we don't ask him, what are you doing? He just looks like a mad person. But he's doing something that makes perfect sense to himself. If and when we have this information, if we have the capacity to the resources, can we make a real workplace for this person and channel all this energy in something real? Because he clearly still wants to do things. We just need to help him in the how. Okay.
Okay, thank you, Dr. Eva. So we need to assess more deeply, like with CDR and doing our observation,
Mhm.
and we need to not to jump to conclusion because we have our own stigma for the older or dementia. So that was wonderful. Yeah. So just ask them directly. Thank you, Dr. Eva. We have two next question from because our limited time
Yes.
yeah, maybe uh, uh, I think this is the same question. I will combine the question. So
Yep.
uh this is how we can differentiate about dementia and major depressive disorder, or
Mhm.
the combination of it. Is it allowed to administer antidepressant to patient with dementia? And I think it is the same with the second question. Is how to differentiate delirium,
Mhm.
depression, and dementia, or
Yep.
maybe delirium superimposed with dementia, the 3D,
Yeah.
when particularly when the patient baseline cognitive function is unclear, because maybe in this
Yes.
three disorder have a decline in cognitive function.
Yes.
Okay, Dr.
Yes.
Iva.
Thank you so much for these questions as well. I'm going to start with this is so incredibly difficult. I think when we start talking about our brains, everything seems to be interrelated. So I don't even have a clear answer to this. I think the easier part is the delirium because the onset is so sudden, and that's your trigger that something happened, something ameliorated their symptoms, and it's going fast and it's going up and down. It's very erratic. And it's often related to hospital admission. So if you have a combination of somebody is moved from their familiar environment and has very, very acute symptoms, that's when you have to consider delirium. And then you can do all your medical tests, right? What is their hydration like? Like do all your blood tests and try if you can find an acute cause of these changes in behavior. Between depression and dementia, I wish I had a better answer, but as I try to relate in my lecture as well, I think it's near impossible because they're so interrelated, and older people with depression look so different than younger people with depression. It is very hard to diagnose MDD by itself. And then you add this other dimension of dementia to it. Is it permissible to administer antidepressants? I think this is every individual's choice, right? It could be a pathway to discovering if you have found an antidepressant that's generally working. It could be a path to you discovering what's going on. So you might start this and closely monitor if it makes a change at all. From my perspective, and I'm a psychologist, so I have a different first step, I would rather look at non-pharmacological therapies. So you can think of, I don't only want to say talking therapy because that's definitely not the only road, but you could have people do exercise, structured exercise. Again, there's a lot of Lancia groups that will have like morning activities. Let the person join those and see, once they start actively moving that body, does it lift any of the symptoms? And that would point a bit more to depression, even though physical activity also really important for dementia. You could think of art therapy, just maybe even getting people out of their social isolation. But I would say it is very difficult and it is a long path to walk. So you could also consider, do I need and can I even really find out what's going on? Maybe walk that path, but at the same time start targeting the symptoms. Because that's your way in, regardless of what underlies what's going on. So if a person becomes very withdrawn, it could be due to either one or both at the same time. It can be great to find out, but it doesn't change that we can start working on, okay, how do we pull this person out of their shell and they become less isolated? And then we can monitor what happens. So I think these questions are so important. And I wish I could say you need to do this, this, and this, and then you know what they have. But in my experience, that's exactly the biggest challenge we're facing. The diagnosis is helpful, but virtually impossible. But again, this is not, this, it doesn't, for me, with my experience now, I don't mind, because there are symptoms that we can work on. So I know this is not the answer you're looking for, but this is my take on, okay, we need a whole new paradigm of dealing with these. Because again, if I go back to that broken leg, we know what to do, we know how to fix it, we know how a person rehabilitates, and if something goes different for one person than the other, we still have protocols in place. And that's just not the story for both dementia and depression. There's a lot unknown.
Thank you, Dr. Eva. So it is challenging to differentiate the 3D delirium, dementia, and
Yeah.
depression.
Yeah.
And yeah, thank you for your answer. For we need to differentiate it from the onset, and yeah, we need to focus on the symptom or the behavior, right? So we can learn about what is the cause of this, and yeah, maybe we can start from the non-pharmacological intervention first. Okay. Thank you, Dr. Eva. I think because our limited time, so we will take a break for 10 minutes, and after that we will come back to the second lecture. Thank you, Dr. Eva and fellow participants. We meet again at maybe 20 and 45. 10 past 45 EM, Jakarta time. Okay, see you. Hmm. Hello, everyone. Hi, Dr. Eva. How is your break?
I got up and moved a little bit.
Oh, okay. Yeah, I think we
So
need
good.
some little move, so
Stretch
we are
our
not
legs.
stiff in our hands or maybe our legs. Okay. Uh, is everybody ready? Uh, where is uh, where is everybody? Okay. Um, I think we need to continue our second lecture. So Dr. Eva, you can start your presentation about maybe 1 hour.
Yes.
Okay.
Okay.
Time and screen is yours, please.
Thank you so much. Okay. Gonna dive right into it. So the program for this second part is I'm just briefly, very briefly, not doing it justice, but summarize the pharmacological treatments. I will introduce unmet needs theory that can help shape what we would and can do. Some suggestions for paradigm shifts. Our way of thinking about dementia is basically at the essence of what we can then do. I would like to explain to you implicit memory, which is available often to people with dementia. So again, this is going to be probably the most hopeful part of the whole section today. And then how we can adapt the environment. And lastly, as an example of non-pharmacological interventions, because there are quite many around, I would like to present the work I did in Melbourne with a great team of people on the Montessori method. And I'll explain the method a little bit as well. So I want to just briefly start with pharmacological treatments. And this specific incident in 2023 is still very fresh on my retina or in my mind or in my sadness, because the headlines online on the newspapers everywhere were, we have a breakthrough in Alzheimer's treatment. And the reason that makes me sad is that I had a lot of people living with dementia and their family members who were over the moon by this announcement. The medication was approved by the FDA, and it was supported by a study that said, well, it slows decline of memory and thinking. So this is great news, right? But as I said at the start of my first lecture, sadly, it's not that straightforward. I think all of us should be in awe of our brain. And it's, again, I'm going almost into philosophical issues here, like with what our brain is and how far can we understand the brain. And that is a circle. It's a circle of thinking that you can't get out of. Like, are we ever capable of understanding our brain completely? And probably not. So as much as I appreciate the ongoing work for medication, I think the communication around it needs to be more careful and more nuanced, which obviously is a clash with how the media would present something. So I'm not pointing any fingers anywhere. But if we look at the fine print for lecanemab, first of all, it worked mainly for white men living in urban areas. The treatment is extremely costly, which means it's out of the question for most people living with dementia. There was not an abundance of side effects, but side effects could include brain swelling and hemorrhage in the brain. Why do we make a headline that we have a breakthrough when very serious things can happen as well? But the saddest part of all of it was, when you read the articles underlying this presentation, it turned out that this medication works in the very early stages only. So it does slow memory, the decline, of memory and thinking. But it slows it in a stage where most people will not even visit their doctor. They're not aware that they're in the early stages of dementia, so they will not seek medical assistance. And that kind of almost cancels out the whole breakthrough, because the people who could benefit from it are not aware they need it. So how are we going to target it? A very short summary in full respect of all this work that's being done and thankfully continues. And I hope that people will continue to keep looking for medications that can support the recovery or the slowing down of dementia. We also have to ground ourselves in today and the reality that there is no breakthrough and there is not a working medication. There's no wonder medication that will cure or prevent dementia. As I said again at the beginning of the first lecture, there are some medication that will work in some stages for some people. And that is something. I don't want to disregard that. But we need to move on from there. And also these symptoms like hallucinations and depressions, there are treatments available. I think being around for almost 2 decades in our field, the next sentence is ironic, right? Because I've been hearing in the next 5 years, for now over 15 years, in the next 5 years, we'll have medication available. And that sums it up. Again, I understand how difficult this is, but I want to move on. And whilst this important work is being done, I want to make people's life with dementia, people with dementia's lives better today. And so we cannot do that yet with medication, but that doesn't end the story. So I want to talk a little bit more about misunderstood behavior that I introduced in the first lecture. So the idea of reframing what was previously, or is still called quite often, behavioral and psychological symptoms of dementia, or neuropsychological symptoms of dementia. I want to change that paradigm of, I'm sorry, I'm just repeating myself, but I think it's rather important that when we speak of the symptoms with those terms, they become inevitable. So a person has dementia, we realize they have dementia because they have these behavioral and psychological symptoms. And because they have the symptoms, we know they have dementia. And then it's inevitable because it seems to tell you that these symptoms occur and there's no way they cannot occur because the person has dementia. And that ends the story, right? Then we get to that message, but so many people with dementia receive, there's nothing we can do. It's not the whole truth, thankfully. So without maybe directly targeting memory loss, but starting to focus on implicit memory, that I will talk about more, but also brain plasticity and environment to support the people, we can then start working on symptoms. So for me, I will use the word misunderstood behavior because it involves us. It takes us from the role of a prescriber of maybe medication that is available to I'm a detective and I need to find out what this person is trying to communicate with this behavior. Just some numbers to share with you. So around 40% of people who had dementia also had some depression and anxiety symptoms. That goes back to those questions at the end of the last lecture, right? That's a high prevalence. And then between 50 and 80% in a study in the Netherlands showed what we call those misunderstood behaviors. So you can think about agitation, wandering, aggression. So that's an even higher percentage right there. Also, misunderstood behaviors really impact the quality of life and increase the burden of the family carers, other people around them. And again, this is a study from the Netherlands. It was the main reason that people had to move from their familiar homes into an institution. Now let's dive into kind of breaking that circle of dementia, so these symptoms just means dementia. I want to suggest, and with me is Jiska Goen-Mansfield, Dr. Cameron Kemp, and many other people who have inspired me, that there's a mediator. So the reason for behaviors, yes, it changed when they had dementia, but there's something between the dementia and the behavior. And that's something that can be a whole lot of things that can be targeted. So what Jiska Cohen-Mansfield, who postulated, shared the unmet need theory with all of us in the dementia field, said, problem behaviors of people with dementia result from unmet needs, basic needs, stemming from a decreased ability to communicate those needs and to provide for oneself. So the minute a behavior becomes an expression of an unmet need, there's an intervention possible, usually. So the first question when you see somebody with dementia, potentially suspected dementia, is what is going on for this person today? Why do I see this behavior? And the answer cannot be because they have dementia. We need to find another answer. And there usually is. Let's look at examples of unmet needs. We can think of physical needs, and I think pain would be the biggest one. There's increasingly more studies, or maybe the peak has passed, but of people giving simple painkillers to people with dementia just to see if that would reduce their behaviors. We can think of psychological needs. Hallucinations can be very real and very frightening. Depression obviously needs to be in that line as well. Then we have cognitive/activities needs, so an over or under stimulation of the brain, and both can be really triggering for people. We have needs of physical environment, so this again goes to very overstimulating environment. If we think back to the 10 signs, the warning signs of Alzheimer Indonesia, it was right there. People start withdrawing from social interactions because it's overstimulating. The way I always describe people with dementia is that us with healthy cognitive functioning, we have filters. So you are listening to me, you will have a lot of background sounds that you're quite well in blocking out. You might hear them, observe them, but you don't latch onto them. And I always have the feeling that for people with dementia, this filter has been ripped out and all the information comes in all at once. And it's very hard to distinguish between this is the most important, this is more peripheral. So the physical environment and the social environment are extremely important. So social environment can also be related to noise, but it can also be the opposite. So a lack of company. In that study here in Indonesia, there was a beautiful, one of the outcomes was that as long as people were part of the community and included, they functioned really well. So there's really something, a social component to this. And if we summarize all of this, again, Dr. Cameron Kemp, my mentor, said, look, we all need a reason to get up in the morning. So if we don't have activities because they've been taken away because we made a huge mistake, we don't have a role anymore, we're not taking seriously, our family members are all doing what they are doing, and I feel like they've forgotten me. It kind of feeds into the narrative and make things much worse. Cohen-Mansfield did a great study where 2 professionals assessed the top 3 unmet needs of 89 people with dementia. And you might be surprised that the physiological and the psychological needs didn't make the cut. So it's much more, number 1, about boredom and sensory deprivation. So understimulation of the sensory. So a very bleak environment. I believe these studies were done in nursing homes, which often try to work with a one-size-fits-all and also have a very clinical environment, very hospital-like, just because of the practicality of it. But that means its sensory input is very, very limited. The second most observed unmet need was loneliness and a need for social interaction. And the third one was a need for meaningful activities. We're all aware that we don't have medications to reduce boredom, loneliness, or a lack of meaning. But this is where those non-pharmacological interventions come in. We can stimulate people's senses. We can create a rich environment where people can choose to interact when they want to and can, and where they can withdraw when it becomes overwhelming. We can help them find more and better connections, and we can keep them active and let them participate. Just as an example, something you'll see a lot in nursing homes, so in institution, is that people shout out, which again is the same as the man who was moving the furniture. This can agitate a lot of other people. And sometimes people just shout help over and over and over again. So it's very agitating. But if we dive into, so the person is not shouting because they have dementia, because that stops what we can do. But what if the shouting, just an example, is related to a fear? Because this person is disoriented in place. So they do not know where they are. If we go within ourselves and then realize, okay, what if one day, or maybe every day from now on, I wake up in an unfamiliar environment? Some of my books and a plant is there that I know belongs to me, but they're not in the right room because I've moved into an institution. I'm not lying in my own bed, and this is definitely not my room. And when I go outside my own room, this is not my house. And there are all these people around that I've never seen before. All of a sudden, we've placed the shouting into a context where it makes sense. I would shout if this was my current situation. And I would shout for help because I don't understand what's going on. I think because of our limited time, I'm just going to show you this. All of this fits beautifully in the person-centered care theory of Kitwood. These are his main domains of unmet needs, or where we can meet needs. So we're talking about having an identity, having an occupation, being included, being attached to something or someone, and comfort. And all of that, he says, goes back to a sense of love, or I would almost say safety. This could be something to note down and dive into a little bit yourself, because the model is beautiful and very comprehensive, I would say, of the things that especially people with advanced dementia are still really craving and often not getting anymore. From my own practice, I want to start, before we dive into one example of a non-pharmacological intervention, I want to propose a couple of paradigm shifts. So first of all, I think I've highlighted this a couple of times, but to rephrase the symptoms that we see as misunderstood behavior. And that, yes, this person has changed, their cognitive function has changed, and that leads to impairments in communicating to us. Because we called it misunderstood, it means the problem lies with us and the solution lies with us. We can find out why they're having this behavior. And thanks to the great question before, we find out first and foremost by asking the person themselves. If they cannot articulate what's going on, we can refer to observations, looking into the personal history, and we'll find a lot of information that will help us. I've mentioned this all the way at the beginning, but of the first lecture, I would like to highlight it again. The story of dementia is one of loss, grief, sadness, helplessness. And I don't want to wipe that out. I think it makes a lot of sense that you, or if it's your partner or your parent, changes significantly, you're going to experience loss and grief and sadness. But we cannot stay stuck in this place. So one of the metaphors I use is, look, we're on a train track, and the left track, so you have two tracks. The left track is all about this loss and sadness. And if we walk just on this path, we'll always be sad. We'll never do something because we believe nothing can be done. And we'll get more sad because it's awful to witness. On the right side of the track, you could see what you can call toxic positivity. So, yes, we have dementia, but we're going to keep going. We're going to keep our head up. It's probably not as bad as it seems. That sounds good, and it sounds like a fighting spirit, but it will bring you back in the end at the exact same point when you just feel helpless and sad, because that's also not the only story. So if we can walk the middle and have one foot in the grief and the sadness and one in the possibilities and optimism and hope, we integrate it and we let this part be, but we work on the part where we can. So let's shift our attention in full acknowledgement of the grief and loss, but let's shift to what can be done. What can they still do? So for example, I'm going back because this example came up in our Indonesian-based study, that a woman, and very unfortunately, was a great cook, but she developed symptoms of dementia and she set the kitchen on fire. Which again, we don't have to discuss the danger of that. But what the family did in response, and out of pure fear, it's not that I don't understand, she couldn't cook anymore. And this was part of her structure. This was her meaningful activity. This gave her a position in the family, feeding everyone. And it was taken away in an instant. So this is where we need to shift from an all or nothing. Clearly, we could never put her and anyone else in that same position, that same danger again. But we can make so many adaptations for her to cook safely or to just do part of the cutting, where she maintains her role, her structure and activity. The last paradigm shift, this is one that I haven't mentioned before, is caring for a person is not as helpful as it may sound. So Maria Montessori, who we'll be talking about much more, was a medical doctor and worked a lot with children, but we have adapted her methodology for dementia. But she said, what you do for me, you take away. So again, it goes back to that lose it or use it principle. If we make the decision that the other person can't do certain things, despite them still wanting it, we take away a lot. And I know it's much more work to see what can we still do, but in the end of the day, it might save you time because this person will not deteriorate as fast and they will still very much be part of activities, daily life. They contribute. So I suggest, instead of caring for, some of the nurses I work with, they always put their hands on their back, saying, okay, I can't use my hands. I can't start doing things for them, but we're going to start doing things together. We did a function-focused care study, which basically means that instead of doing the care, the nurses would coach the people. And I remember one of the nurses who was the most resistive went, nah, this is not going to work. Some people just enjoy that we're doing it. Some people really can't. And I remember her telling me that she was helping a man, coaching a man to dress himself. And he managed it. Two, they had a lot of fun doing it together. And three, the goal was achieved. So we start caring with our hands on our back and maybe our mouth closed sometimes, asking more questions than trying to interpret what's going on. So instead of being the observer and sometimes a judge, we can become an actor, an active person in the process of helping this other person. And we also need to become a detective, because finding out what the underlying need is quite challenging. Just to repeat that once more, so we don't accept symptoms as part of dementia. We need to look what's intermediate. And finally, when we start working together with the person, we can steer away from the losses or move those a little bit into the background and focus on possibility and capability. I think so. We now know unmet needs. They would be great. But how do we involve people with dementia themselves? And this requires exactly that change to, okay, where can we still work? Where can we connect? Where can we involve a person with dementia? And that goes back to the types of memory that people have. So, for example, if you are familiar with people with dementia, you know that people have short-term memory issues. So new information is not really stored. The problem is to learn something new, the procedure needs to be stored in long-term memory, and then it can be accessed in the future. Now, long-term memory can be separated into two types, and bear with me when I get to the point of why I'm trying to tell you this. First of all, there's explicit memory, which is episodic, so sequences, stories, and semantic language memory. This goes back to remembering people's and objects' name, remembering recent events. This is highly impaired in people with dementia. So this cannot no longer be our pathway into long-term memory. However, there's implicit memory, and this includes priming and procedural memory. I will explain in a moment. And this does not require conscious thinking. This type of memory is available in people with dementia. So let's look at priming first. This is a learning technique that just exposes the person over and over to a stimuli and a response. I'm sure you're familiar with the Pavlov work, where the dogs would press a lever, a bell would ring, food would appear. And after a while, they had learned the stimulus and the response, and they would start salivating when they pressed the button, because they know the button, the bell, the food. This is obviously a very simple example, but we are all primed into a lot of our procedures. And you can just think of, if you love doing something and you got a lot of encouragement and compliments, that was kind of the incentive that made you get better and better. And so you have a habit there that's been ingrained in who you are. Priming leads to a learned sequence of events. So like I just said, press lever, hear bell, get food. It's very hard to erase when it's learned. For those poor dogs, they also took away the food at the end of the sequence, and it took a very, very long time for the dogs to stop salivating at the time they pressed and heard the bell. And then we have procedural memory, and this is even more our way in with people with dementia. It works with muscle memory, so the body remembering sequences and habitual behavior. And you can, I think a really good example is that when you're walking down the street and somebody wants to hand you something, there's a stranger standing there, they have a flyer for an event. And it really, before you know it, your hand is up there and you've taken the flyer, even you don't want the flyer. And this is what procedural memory is. Somebody wants to give you something, you take it. Your body responded before you in your consciousness went, hang on, I don't need a flyer. I know where I'm going. I'm doing something else. And one of the examples I always imagine myself, my future self, is I'm born and raised in the Netherlands, where everybody rides on bicycles all the time. From very young age, it's our main transportation mode, so we can cycle. And this has, because of the sheer repetition of doing it year after year after year, this has become now muscle memory. It's my habit. So I imagine myself, say, 40 years in the future, and I have some MCI or dementia happening. and you would hand me a bicycle, I could probably get on and cycle away. But I couldn't answer your questions. How am I doing this? How does it work? But my body remembers. And so that's the strength of procedural memory. Your body, your muscle memory, and your habits, they remain intact. It's largely automated, so it doesn't require a lot of effort, and it's largely intact in people with dementia. So all of a sudden there is a way in that we can either relearn old procedures or we can even teach people new ones as well. I remember a man, and we were doing some activities with him, and one of the activities was just looking at certain pictures that we thought related to his interest. And for some reason, the research assistant asked him how many people are in this picture. And the staff would have said, no, this person doesn't have a clue. And he just started counting 1, 2, 3, 4. So there's all these little things that are accessible, but we need to experience it ourselves. I definitely want to spend a little bit more time, and I also have some videos to show you on how this works next week in the workshop. I'm now going to switch my screens. I'm going to stop sharing this one for a moment because we're going to dive into the Montessori method for dementia. Bear with me, please. Let me see. Oh, give me one moment. I'm on the wrong slide. Here we go. I hope this is visible in full screen. If not, please let me know. So this is the non-pharmacological intervention that we've been working with during my time in Australia. And it's called Montessori-based activities for people living with dementia. Like I said before, there was a huge number of people involved in these studies, amongst whom my mentor and supervisor, Professor Daniel O'Connor, and Dr. Cameron Camp is there as our practical advisor about the methodology, and then a whole lot of researchers and research assistants, as well as our funders. So let me first try to explain the Montessori method a little bit. So as I mentioned before, Maria Montessori was a medical doctor living in the early 19th century. She worked in education, basically. She established houses for children of poor people where the children could spend the day and be educated while both their parents were at work. It's very hard to pinpoint what it is. You could call it a philosophy. There's definitely a lot of psychological elements of how what she did worked. But for me, the essence is it's a way of communicating with somebody who expresses their basic needs differently than healthy adults. So again, we become the actor, we are this detective, and with this method, we're asking, how can I enable this person, who in Maria Montessori's case was a child, but in our case is a person with dementia? How can I understand their basic needs? And then we're at the starting point of what we can change. So it places the individual at the center. There is no one size fits all. We do have like Kitwood's model that gives us some context of where we should look, the unmet needs model. These are all things that help us, but we always need to return to this particular person in front of it. The way I would very briefly summarize this method is we adapt our communication to that particular person. We avoid any difficulties, so we're steering away from the loss narrative and we start focusing on what they can do. Now, how can it help? So Dr. Cameron Camp developed Maria Montessori's philosophy communication method for people with dementia. And he also always highlights that the starting point is not a demented person, but it's a person living with dementia who has accumulated disabilities. And when we think of disabilities or a syndrome, we can connect to physical disabilities, right? In the photo, you see somebody's in a wheelchair. Well, people in wheelchairs are helped when we put ramps in place. Now, how about if people with dementia could have a whole lot of cognitive ramps that cater and counter their disabilities? And I remember when Dr. Cameron Camp came to us the first time and he explained it and it sounded wonderful. And then we went to the nursing home and he did it right in front of our eyes. He engaged people that we had never seen engaged. He had a person sit down that we had never seen seated before. She was always walking around. So we became believers instantly. And then we still had to deal with, okay, can I do this? Because it looked like magic to us. So it's a new way of thinking. It requires so much attention. I hope to next week also talk a little bit about mindfulness and how that can help us. And it requires patience and creativity. It requires a lot. So his Montessori method, here he is. This is Dr. Cameron Camp. It works with 10 principles. We, in our research study, applied them to Montessori activities, but try to zoom out from there and just see this as how do we interact and how do we enable people with dementia to function in daily life. So before we interact with the person, I'll choose a little bit different words than are on the slide because those are really related to activities. But so before we interact with the person, we can think to ourselves, what is the purpose? So for example, say you meet a family member who visits or wants to interact with their person with dementia, but they can't really talk anymore. So it's always very sad because we're heavily reliant on conversations. So we shift the idea of the visit. Do they need to talk, or is the sole purpose of having a nice time together? If they just want to have a nice time together, they clearly need to steer away from conversation because it's frustrating for both and it results in a whole lot of sadness and other emotions that just don't help the visit. So instead of talking, can we be doing something together? Be very aware, this is more important for us as professionals than family members who usually know, but really know the person's physical abilities as well. So are they supposed to wear glasses or hearing aid? You can do almost a whole test of functionality. Can they lift their arms? Can they stretch their arms? How about their mobility? Can they walk? Can they read? And I think from Cameron's practice, I really learned that there are so many assumptions and so many no's they cannot, which have never been tested. So one of the things he always does is a reading test. And most people can read. It's just a matter of providing a font and a contrast that helps the person to read. So if we present them with a sheet with maybe blue on a black background and very small font, no spacing at all, they won't be able to read. But if we do high contrast, black letters on white background, larger letters, more spacing, most people can read. So we need to know, because these are our ways in. And we always start by inviting the person. We ask permission. I'm here to visit you. Is that okay? You've come to visit me as a doctor. How do you feel about being here? How are you okay to be here? How are you feeling? It's probably a little bit too complicated. And we give choices. So if we talk about something simple, family carers may tell you they can't dress themselves anymore. And that might just be that overwhelm again of standing in front of a closet that has, say, 7 different pants and 10 t-shirts. It's too overwhelming and basically they choke. So they just match something that doesn't fit, or they wear it inside out, or they put layers on layers. It's just too much. Whereas the step we can put in the middle is one person choosing two outfits that match together, that match the weather, and let them choose. I've never seen a person with even very advanced dementia who cannot choose. And this is habitual again. Talk less and demonstrate more. So this again zooms out to communication. If speech is difficult, we're so conversation reliant, and that can be so frustrating for the person with dementia because they are not. So instead of telling them what you would like them to do, we can just start demonstrating. And that's when procedural memory kicks in. They see you doing something, they'll probably automatically start doing it as well. We may need to adjust our moving and talking speed, but that is highly dependent on the individual. Please don't slow down if the person is fluent and talks beautifully. Just stay them with where they are. We can use nonverbal hints and templates. So again, steering away from assumptions that the person understands our verbal instructions or, can still read the environment. No, we give them templates. So for example, if you go, I want this person to still set the table before dinner. But if I leave them to their own devices, they forget about the plates. There's a spoon when we need a knife. Well, we can make a template that has a drawing of the plate in the middle, a knife here, a spoon and a fork and a place for the glass. The template in itself might need some doing it together a couple of times, but after a couple of times doing this, there's a new habit and there's an understanding of what needs to be done, and the person can do this independently. Again, this is more applying to people with very severe dementia. That's what this study was about as well. But if they cannot actively participate, you can still make them part of what you're doing by giving them something to hold. And we'll see a great example of that next week when I'm sitting with a woman and I wanted her to make a flower arrangement. It used to be one of her hobbies and habit. She couldn't really do it. So I did it myself, but I had still given her, these were fake flowers, by the way, because we do have to consider some things, but I gave her a flower to hold. And that gave her the opportunity that when she clicked, she could join at any time. If I had just left her seated with nothing, she couldn't join at any moment. And you'll see next week, she did join after a couple of minutes. So very Montessori is start working from something really easy to more complex. So let's just say back to that example of a person who would love to cook, but it's not as safe as they used to be. We break it down. This is step number 10. We start breaking the cooking task into all these little jobs. Can the person still go shopping? Do we go shopping together? Can they choose the vegetables, the protein? Every single step. Small steps work much better than the whole sequence. Once we're back at the house, can they unpack the shopping? Will they put it in their right places? When it's time to cook, can they chop the vegetables? Can they put the ingredients in the pan in the correct order, or do we prepare it in a way that the first plate has the ingredients that we put first? It goes on and on. So we break it down in small steps and we start from the easiest way, and we'll very quickly see if it's too easy. Usually the person will tell you, or you will really see it from that they're getting distracted or bored. And then we can say, okay, you do these 2 steps. After finishing something, this is more related again to activity sessions. We can just ask some questions like, did you enjoy that? Shall we do this again? Again, just really giving that person a voice. I think 12 is, the principle 12 is at the essence that there is no right and wrong. And that goes right back into the purpose of what are we doing? So if the purpose is nothing goes ever wrong, that's when we take activities away. But if the purpose is we want this person to stay involved for as long as they can and independent, and have a sense of freedom and importance. That's when we start looking, okay, at what can they do. So our normal idea of what's right and wrong has to shift. It's no longer right that we have a conversation when we sit together and we exchange information and we understood each other. These things are very hard. But the right thing for being with a person with dementia is that you both feel good. I'm going a bit back and forth between families and professionals. I'm trying to think of an example for a professional. I think the aim of a visit could often be to get to the point as quickly as we can. Whereas maybe with people with dementia, we need to more work towards making this person understood and sharing that we don't have the answers, but we are here. Okay, let me focus on some of the work we've done. Just checking the time, okay. This was with residents themselves, so that was our starting point. So all of these people were living in an institution. They had a diagnosis of dementia. It was often intermediate to severe stages, and they needed to have at least one high-frequency misunderstood behavior. And this could not be due to pain, so we ruled out all those other courses and some other, so they needed not have been hospitalized or just started living. This is all too unsettling. And obviously we needed to have consent, both from a relative, because the persons often were, not accountable for a signature. However, if they didn't want to interact with us on 2 occasions, we would stop. We would see that as a non-consent from them. And I think that happened with 1 person out of 40. So we would visit them. Every person was both in the intervention arm and the control arm, just to control for individual differences, daily differences almost. And everybody would have 4 Montessori-based visits and 4 control visits. And we randomized the order. So some people started with the intervention and some with the control. So we had a person who would come in and do Montessori or normal activities, which was just keeping them company and maybe reading a newspaper if that was available. And we would then do observations before this activity leader would come in. So 30 minutes before anything happened. So just to establish a baseline, then 30 minutes during this intervention, and then 30 minutes after. So the person would leave, finalize the activities, and the observer would stay and have a look at these people for another 30 minutes. So the observer would be there for 90 minutes, and the intervention is just for 30 minutes. And for every single moment, we would note if that certain behavior, like I said, it was usually wandering or pacing up and down. We would say, is it present or is it absent? We would note the dominant type of effect in each minute and the dominant type of engagement. And we had high inter-rater reliability. So we ended up, it took us 2 years, and we ended up with 45 people with severe dementia and misunderstood behavior. As quite common, the majority was female, mean age approaching 80, and around a quarter of them had lost their fluency in English. So this happens with a lot of immigrants, that when the dementia becomes worse, they lose the fluency in their second language. Now this is what happens. I'll try to explain it as clearly as I can. But the top pie is the before and after situation. So the red is, they would have the behavior that we chose. They would be wandering or pacing around. And the green would mean they were actually seated or still or calm in that moment. So you can see before and also after, so there was no after effect, they would be active. They would show this behavior for more than half of the time. If we look at Montessori on the bottom left, this would be reduced to around a quarter of the time. So all of a sudden, for say 22 minutes out of 30, they would not display these behaviors anymore. But as you can see, the control behavior, that simple intervention of reading a newspaper or just chatting and being with the person, also reduced behaviors almost to half compared to both before and after. So a huge effect here also. The difference that we saw was in the types of engagement. So here red was a negative engagement, which would be a distraction either with other things in the environment or very self-involved. The yellow, it should say, is passive engagement, where they are kind of staying with the interventionist or on whatever they're doing outside the study at the moment at 30 minutes. But they're not active. So they might be listening or looking. So their attention is in the right place, but it's not active. And then you have the active engagement where a person starts really doing whatever is the activity or becomes very talkative. So again, the top pie is the before and again the after. So again, no after effect. That highlights the importance of needing help of another person. So 3/4 of the time is spent basically disengaged. So no meaningful engagement with anything at all.
Dr. Eva, excuse me.
Yeah.
For 5 minutes left.
Yeah, I'll finish this study.
Thank you.
Let's focus on especially the red part of the pie. So a huge reduction in when we were doing Montessori activities, really, really well able to engage either both passively, but also really, really actively the green part of the pie. And in the control, there's a much smaller reduction. And also the active engagement levels were definitely not the same. So this is where the Montessori, that very tailored way of communicating and involving the person, did so much better than the control. And unfortunately, like I said before, our results for effect were not informative because that minute was just not the right time frame. So the conclusions from this study, and then I'll forward to the end, is that the behaviors that we see can be greatly reduced, but also with just keeping someone company. Something like Montessori, so a non-pharmacological personalized intervention, has a huge impact on how engaged a person with dementia, with severe dementia in this case, can still be. And people who couldn't speak anymore benefited even more. I haven't presented the pies, but that was a finding as well. And there was huge individual differences between all of this. I'm going to pass forward here. So we did 2 other studies, one where volunteers, we explored the interest of volunteers to work, with people with dementia, and that worked out very well. They were very happy to have something actively to do. And our last study was with family members themselves. And again, we saw the same effects in engagement of the people with dementia. They became much more engaged doing Montessori. And we saw an effect on the family members that the visits just became more enjoyable as well. So the conclusion of the 3 studies was there were big effects on active engagement, interest, and positive effect for the residents, and the experience of the visits for the family members. We didn't see a lot of carryover effects, meaning that once the person left, the behaviors went back to baseline. So really highlighting that the help of another person, a person who understands what's going on and supports them in a better way of communicating, is really essential. Also, really acknowledging that control condition, the sheer keeping somebody company is a huge change in this environment. And so families and volunteers are able to do this. This is a quote from one of the dementia behavior consultants, very specialized, trained person who already had a lot of knowledge, experience, expertise, and was willing to learn about the Montessori method for dementia. And she said, it has not only changed the way I worked, it has changed my life and all my daily interactions. The overall conclusions, maybe zooming out and making Montessori representative of non-pharmacological, highly personalized interventions. This is applicable in all care settings, not just in institutions, because we can personalize it, we can adapt it. And the essence of it is making this person the center and work from there. So we look at their symptoms, we work from there. It makes it very time intensive to learn, and it's a lifelong learning because every person will be different and will require something else. And so it also needs continuous supervision and discussion. You can't do this on your own. I still talk to Cameron when we're doing this every time. However, continued learning, time investment, it will improve the care and the lives of people with dementia and those around them. And after an initial investment, it may actually save you time and become enjoyable for everyone. Recommendations for any implementation, this will be almost the last slide, is so always invest in training and continued supervision. Don't do a 1-hour workshop, have a certificate and think you're ready to do this. This is really, really hard. Start with the people, your colleagues who are interested and also believe in it. That's your best starting point. And by observing you and your colleagues that are interested, others will also get interested in what you're doing and will be willing to give it a try. But working with people who don't think it will work is very hard. And make sure you have experts. All right, these are all the publications that we made from these studies. You can find them on PubMed, and these are the references used in this presentation. And finally, this is a comic from the Netherlands, a duck and a chick, who says, the heading says, oh, we know what it's all about in science. And the one on the left says, this is so impressive, my colleague, but does it work in theory? I think that's one of our main challenges, that we have a lot of anecdotal evidence that we can help people with dementia, but building this evidence base is very, very hard. And let's open to questions again.
Yeah. Thank you, Dr. Eva. Yeah, it's very interesting and good presentation. Yeah. It's fun, but it's very challenging too.
Absolutely.
Uh,
Yes.
yeah. To do a behavior analysis, especially for non-pharmacological intervention. We have two questions from the chat box from Dr. Levrita from internal medicine trainee. Uh, According to the unmet needs theory, how should clinician approach agitation or other behavioral symptoms in patients with dementia?
Yeah.
Thank you.
Great. I think the minute you have somebody with agitation, you have to put your detective cap on, and you first need to know what causes the agitation. So again, there's not a one answer. So we could put the person on a painkiller for a short period of time just to see if that reduces the behavior. Or we could try to score them on a pain scale by observation, or obviously ask them, first step, if they are in pain. But this is one of the things that's quite hard for people to communicate. There are scales available that works with kind of smileys, and ask people to score their pain by pointing out the face of the smiley. So I feel mildly uncomfortable, or I'm very, very deeply in pain. But so there's already stages to how we can test that. I mean, agitation is one of those symptoms. It could be related to anything. It could be related to pain. It could be related to hallucinations. It could be related to disorientation in place and time. It could be related to having nothing to do, being completely understimulated and looking for something to do, like the gentleman who was moving all the furniture, which was labeled as agitation. It could be the opposite. It could be overstimulation. So the person just has so much input that their only response is to try and walk it off, or to try and get away and start banging on the door shouting, I want to go home. So the first steps will be, what is causing the agitation? The agitation is not information enough to know what we're doing.
Thank you, Dr. Eva. So every behavior they have a meaning. So That's us for the clinician or uh, the researcher who needs to seek what is the meaning of the sim of the behavior. And the second question is practicing from the Dr. Soti Siswoyo. The question is practicing the visualization of positive or good things highly beneficial and helpful in preventing and managing dementia? Is
Oh,
a visualization
yeah, beautiful.
technique. It will be good for dementia.
That would be a great something to study, first of all, I think. The first thing that pops in my mind is a family carer who shared with me that her father would have horrible hallucinations where he thought he was in a boat at sea and the sea was rough, the boat would capsize and he was drowning. And that was a repeating hallucination. In an example like this, obviously to try and visualize something beautiful and positive is a bridge too far, right? I'm sure uh, you all would agree. So what she would do in that moment is actually join him and be on board with him and go through the experience together. It was awful for her, but it didn't last much more than 5 minutes, and it seemed to bring some relief. So that would be an example where visualization of something different is just not available to the person. So again, going back to it's highly individual. I think one of the things, especially when a person has very repeated behavior, is we can do two things. We can start exploring and start talking about it. And like what if a person keeps saying, what's the time? Or has my son already visited? Or we start asking them, what's the reason? Why is this important? Some of it's really obvious, but we want to hear it from them. If that doesn't bring you anywhere or it doesn't help the person, we can move towards distraction. And that's again where activity is coming in. So we steer away from conversation, but we provide enough meaningful activity, so not just anything, that will just take the person, literally take the person's mind off what they're doing. I think earlier in the dementia trajectory, because I'm very much, because of what I just presented, thinking about those people with moderate and advanced dementia, where visualization is it's a very abstract thing, right? It could be too difficult. I think in the beginning, and also something like meditations, transcendent meditation apparently helps some people where they kind of manifest certain things. So I would love for you to try and hear back, and I think it will definitely benefit people, but not everyone.
Yeah. Thank you, Dr. Eva. So it is individually. I think it's worth it to be studied. Yeah, maybe for the residency if you want to know about
Yeah.
the effectivity, especially maybe in our culture because I think it's different because how we learn when we learn about relaxation or mindfulness that led by Western people, Dr. Eva. Sometimes the words is um, important, especially in behavior intervention. Yeah, I think it's a good idea for the study. Dr. So this is for you. Thank you for your question. Okay, I think yeah. I think that's all for the question. Yeah, thank you, Dr. Eva, for the time that you have given for us. Thanks for having us, and thank you for Dr. Sri Sunarti to make this three in one event possible. Thank you for all participants who attend this webinar. Before we close this, we will take a photo together. Can everybody of you open up your camera? Boleh buka kameranya buat Prof. Dokter-dokter sekalian. Kita mau ngambil foto, mungkin boleh dibantu ya, adik-adik residen.
Sudah siap semua nggih dokter? Izin saya
Ah,
screenshot untuk yang pertama, 1, 2, 3. Tunggu sebentar. Untuk slide yang kedua, 1, 2, 3. Sampun, matur nuwun.
Okay, terima kasih. As we come to the end of today's guest lecture series, I would like express our sincere gratitude to Dr. Eva van der Plo for generously sharing her knowledge and valuable insight for us into dementia care and dementia research. We also extend our appreciation to Dr. Sri, all faculty members, participant committee members, and everyone who contributed to making today's event a successful one. We hope today's lecture will enrich our understanding and inspire our further learning, research, and collaboration in dementia care. And we will continue our collaboration with Dr. Eva. Thank you once again and for your participation. I wish everyone good health and continued success. Have a wonderful day. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Eva.
Terima kasih, Dr. Eva.
Yeah,
Terima kasih,
sama-sama. My
Dr. Sri.
pleasure. Thank you.
See you at the next
Yes.
session at 3
Next
and 1 series next week. Thank you, everyone. Have a